Okay, so I'm gonna start, and you wanna take on technical challenges?
Yeah, go ahead.
So there's a couple folks in the room that I don't know, so I'm gonna pick on you guys.
Sure. I'm Denise. I work at Fountain House. I'm also a master's student in psychology at the New School.
Oh, nice. Fountain House is great. You got Ralph over there. You got, I know a bunch of folks. You got Ken.
Yeah,
I know folks
Ken.
over there. Okay, good, good.
Hello, I'm William Robinson. I'm a graduate student pursuing MPH in Health Policy Management. I'm also the Graduate Student Government Association President and was featured in the Student Spotlight. So I'm very interested in also learning about these mental health service assessments as well.
Oh, cool. Okay.
I'm Susan Kaplan. I'm on faculty at Rutgers, State University of New Jersey.
Yep.
And I've done a lot of projects on mental health literacy in the Latino faith-based setting in New York City
Uh-huh.
and in the Dominican Republic.
Oh, nice. Well, welcome. Okay, I'm sure you're gonna have some things to add too, which is great. So I'm gonna go ahead and we'll wait for technology to catch up with us here. And what I'd like to do, aside from advancing, is to have some interaction. So rather than do questions, we'll just sort of have some back and forth. So I was asked really to talk about screenings. I'm assuming, oh, good. So you're gonna, can you just manage that? So I was brought in to sort of talk about screenings and a little bit about what's going on in healthcare. But I thought it would be really helpful to just do a little bit of an overview because New York is really one of the more complicated states when it comes to how we have services arranged. And some people may or may not know that, and you have to really take it into consideration when you do pretty much anything and everything, screening, doing any kinds of initiatives. And so really wanted to talk very quickly, cover some of the licenses that are in New York. So what are the different licenses that cover services in New York? Do we know them?
NP, PsyD.
Okay, so organizational licenses.
Oh,
We're going to
okay.
get to professional licenses. Yeah, organizational licenses. So if I do primary care, I'm in Article 28, right? You hear that term a lot, right? If I do mental health, I'm a what?
Article 31.
See, I told you, right? And if I do substance abuse services, I'm Article 32. If I do developmentally disabled services, I'm in Article 16, right? And so those don't necessarily overlap at all. And so I spent the day going around the Bronx to organizations, helping them do integrating their primary care and behavioral health. And the first thing we talked about is what licenses are you, right? Are you licensed mental health? Are you licensed primary care? Or do you not have a license? Are you a private physician office, right? Or a private clinic without any kind of state licensure? Because in New York, the regulations are different for all, and the way they can bill is different for all, and how they get reimbursed is different for all. And so really having to sort of keep that in mind, right? So then we have all of the different licensures, so some of which you were talking about before, right? So you said what? PsyD, NP, PA, PhD, LCSW, LMSW, LMFT, LMHC, who else do we have? MD,
Occupational therapist.
OT, right? Okay, KSAX, right? So you have all of these different people in the mix, some licensed, some not. And some, like if I'm a licensed mental health counselor, I can't bill in an Article 28, but I can bill in an Article 31. So there's all of these different nuances, right, that you have to know in order to be able to do this work, right? And not only does that matter for the state, but if I'm an LMSW, I can't bill Medicare no matter what licensed facility I'm in, right? But I can if I'm an LCSW. So that's why it's so important whenever we do this to really make sure what kind of facility are we in and what professions do we have, right? Because the varied payers reimburse differently. Some of them don't recognize licensed mental health counselors, some of them don't recognize physician assistants, right? So it really depends. And so it's almost like you have to take all three of those into consideration whenever you're going to do any kind of initiative, right? And then because New York wasn't complicated enough, they decided to have an integrated license. So if you had two or more of the other licenses, you could get an integrated license, which sounds like a really good thing, right? You're thinking, oh, this is good. Instead of 2 licenses, I have 1. Except, if you're a federally qualified health center, then it doesn't make sense, because you actually aren't entitled to the extra money that they give for an integrated license, and you may lose some visits. So that's why it really depends. So when we talk about all these things, and we talk about integrated care, and particularly we talk about screenings, every place that I do a screening and who does the screening matters. And those are the kinds of things that you have to think about. So talking a little bit about integration and some of the things that fit into this. So let's talk a little bit about DSRIP. So where everybody's DSRIPing, right? You can't be your community-based organization, medical, mental health, right? So who can tell me a little bit about DSRIP? Why is New York DSRIPing? And actually New Hampshire's going to DSRIP too. A couple other states. Washington's DSRIPing. What's the whole point? Why are we doing this? My public health students, why are we doing this? What's the point?
Money.
Say that again? To improve quality, right? One would hope, okay? So yes, because the quality, we have some of the worst quality scores, right? So yes, ultimately it's to save money. With a reduction in emergency room visits by 25%. And the way they set it up is that if one network fails, they all fail. Everybody's interdependent on each other. So does everybody understand have you had any exposure to DSRIP at all? Because this is a multi-billion-dollar effort in New York to sort of transform care. So maybe just to take a minute, right? So this Delivery System Reform Incentive Payment Program was put out there to transform services to save money and improve quality, right? So how did they set it up? They put out a call for organizations to be what's called PPSs, or networks, right? And these networks were going to be compilations of healthcare, community-based organizations, mental health organizations that were going to be like service networks. And you had to apply to be a service network. And this is a wonderful thing, except for the fact that you had to complete a financial viability application in order to be a network. And the only organizations who could pass that viability assessment were the big hospitals. Because essentially, you had to assume risk for any organization in your network. So if you were a mental health provider and you went out of business, I had to cover that. And the only ones who could do that were the big hospital systems. So you can imagine that created a little bit of an uproar, right? So then the next thing that came up was they put out projects, and they put out 11 of them. The one that we work with most often is integrating primary care and behavioral health, which is affectionately called Project 3AI. There's integrating behavioral health into primary care into behavioral health, and collaborative care, which we'll talk about, right? But there were 11 projects, and each network had to pick from those projects. And if you were doing really good at something, like you were doing really good prenatal care, the state wouldn't let you pick it. You had to pick things that you weren't that good at. And you had to pick from these 11 projects. And then you put out to your network organizations which projects of the ones you picked that they would like to participate in. And the first part of DSRIP was really pay for participation, to come to committees, to be a part of the process. And then the next part is pay for reporting. So I'm reporting on quality measures, reporting information, right? And now it's moving to pay for performance. So the way that people have really struggled with these PPSs is a couple of things. So one is that these PPS networks got millions and millions of dollars, like $250, $260 million, Mount Sinai, Westchester Medical, all those folks, right? And they got paid based on the number of people that were attributed to their network and the number of Medicaid patients. And so how did Medicaid patients get attributed to their network? What do you think? How do you think they figured that out? What do you think they gave credit? Primary care? So the number of Medicaid patients that got primary care from a primary care provider in their network, the number of Medicaid patients that were in a health home in their network, that's how people got attributed to the network. So there was a big discord between the primary care providers because they're saying, we're doing all the work on these projects, you got all the money, and we're the reason you're getting the patients. So the mental health providers really got left off the table, quite frankly. And the community organizations as well. Even though they tried to give it a little, like, we want the community organizations to be at the table, at the end of the day, financially, they didn't have any value. And so most of them wound up not really getting a lot out of the transformation, right? What it has done is allow for a lot of integration work to happen. And so we've been doing a lot around 3AI and sort of doing some of that training. But virtually every organization in New York State is in a PPS. Whether you're a community-based organization, mental health, primary care, for the most part, most organizations are in at least one PPS. And I know when I was in my former life, I was actually in 4 PPSs. And we had to divide up among the senior leaders all of the different committees and take responsibility. So let's talk about, ambulatory payment classification, not where I was going here, but that's okay. Its APC is advanced primary care. So advanced primary care is the New York version of a patient-centered medical home. So what does it mean to be a patient-centered medical home? What is a patient-centered medical home? Anybody know? Go for it.
I'll go. I would say that it is a integrated process that includes a certain percentage of Medicaid eligible patients as well. So it basically is meant to expand the coverage that's available to people within any kind of cluster.
So there are a lot of efforts like that, and we're going to talk about them for certain. There's a lot of innovation projects that are exactly what you described. When we talk about a patient-centered medical home, primary care organizations can apply to the National Center for Quality, NCQA, right, to be a patient-centered medical home. And they have to fill out an application. And the last application I filled out, I sent in over 600 pages. So it's a fairly lengthy application because you have to prove things. If we're integrating care, we have to send meeting minutes and chart notes, right? If we're following up on referrals right away. So the things that make a clinical home for patients, one-stop shopping, follow up on referrals, care plans, right? Being able to choose providers. Those kinds of things make an organization a patient-centered medical home. So you ask, why would organizations do this if I'm a primary care provider other than it's the right thing, right? Why would I do this? Because I get paid more money. New York State actually pays me $7, $8 more for every Medicaid visit if I'm a medical home. So now New York came up with advanced primary care, which is the New York version of patient-centered medical home. And actually in April, they're going to announce that organizations who are already patient-centered medical homes are going to have to reapply and go through the process again to be, you look shocked, they're going to look shocked too, patient-centered medical homes under this new Medicaid, New York version. So people are going to be really happy about that. And then there's a lot of licensure changes in terms of integrated care and doing that. So when you're doing some of these work, so when we're talking about some of these initiatives and screening, why am I talking about some of this? Because if you go to organizations and say, we think you should, everybody wants to screen for trauma now, right? We think you should screen for trauma, and I'm not anti-screening for trauma, but you can see a primary organization says, are you kidding? I'm in 10 district projects. I'm trying to go for PCMH. I'm working on my advanced primary care, and you're talking to me about trauma screening. I think not. Right? And so you can see how sometimes with all of this stuff going on in healthcare and all of these things happening, that sometimes to do some of this work, it's a little bit of a discussion. So the other thing I put in here, just so you would know about it, because I kind of want you to know the landscape a little bit, right, are CCBHCs. So these are Certified Community Behavioral Health Clinics. I was actually in one today in the Bronx. And essentially, does anybody know what an FQHC is?
Oh, federally qualified healthcare center.
Yes, I knew I liked you. Great, yes. So FQHC. So what is an FQHC? Is it just any old health center? What is it? What makes them different?
I guess it's that it basically is, of course, federally funded, and that it is receiving its funds exclusively from the federal government, which basically runs up some entitlement reforms that were passed certainly in the 1990s, such as PRORA, the Personal Responsibility Worker Reconciliation Act.
Right, and yes, and so, and it's tied to a lot of AC. Yes. So the FQHCs, right, they get federal funding, what's called 330 money, right? This 330 money, they call it a grant, but it's not a grant. It's actually based on the number of uninsured that you see, and it's meant to support the uninsured and the underinsured, which is part of the mission of federally qualified health centers. Federally qualified health centers have federal designation, and that's important for a couple reasons. One is because they get this 330 money. The second is they get what's called a PPS rate, which means no matter who they see or who sees them, they get paid one rate. If a patient comes in and sees the dentist, the social worker, the doctor, it doesn't matter, that organization gets paid the same rate for every visit, called the PPS rate, right? And also, federally qualified health centers get what's called FTCA coverage, which means that the federal government pays their malpractice insurance, which saves them millions, particularly if you're doing OB care, right?
Yes.
And so that means if I'm going to sue an FQHC, I'm suing the federal government, which is a little bit of a discouragement, right?
Yeah.
So that's what it means to be a federally qualified health center. That and you have to report quality measures to the government. You have to participate in the federal pharmacy programs. There's a couple of other things, but for the most part. So the community mental health center said, wait a minute, we're really struggling. We think we should get a PPS rate like the FQHCs, and they advocated and they won. And they got these CCBHCs, which essentially are federally qualified community behavioral health centers. So now these centers get a PPS rate. They get reimbursed one rate, and they have to report quality measures. So that's important to know because that's new. And New York was only one of a handful of states that have a pilot project. And it's still up in the air. This was a pilot. It's not sure if it's going to be continued. If you ask the National Council, they tell you it's going fabulously. If you ask some other folks, they say not so sure. So it's a little bit up in the air. But I think they probably will continue the ones that they have. So we talked a little bit about payment, which is really important. We talked about PPS rates, right? APG rates. If an organization in New York doesn't get paid PPS rate, they get paid APG rates, which means that they get paid for the services that they provide. And there's different payments for different services, right? For a medical provider, for a social worker, sometimes if I see someone and use a different language or see them after hours, right? And that's in a fee-for-service model, which means that I provide a service, I get a fee, right? I have a visit, I get a fee, right? And we are switching in our system from fee-for-service to value-based payment. So what does value-based payment mean?
Outcomes.
You get paid for outcomes, right? Or I get paid less. So if you have diabetes and you don't get better, I get paid less, right? So I've got some skin in the game. So let's talk about abstract dollars because this comes up a lot, right? Whenever I talk to organizations, I say there's two kinds of dollars, right? Both are good because all dollars are good, right? So I say there's dollars in the door. Sean's laughing at me. Dollars in the door, right? And then there's abstract dollars. So abstract dollars are things like, I put a behavioral health provider in there, and patients are more likely to keep their primary care visits because it's one-stop shopping, right? So those kinds of things. So in other words, they're not direct, but they're things that you're going to get more revenue because of changes you're making in the practice, right? So it's helpful to think about some of those. So sometimes I say, what are your direct dollars and what are your abstract dollars, right? So when I ask my students that, I say, what are the direct dollars and what are the abstract dollars, to think of things in both ways, right? So thinking about a case rate, and this is becoming more and more important. So we're going from fee-for-service and also doing case rate billing now. So this is more and more popular, and organizations are really struggling with this because our billing systems and our electronic records were not designed to do this. And even your most sophisticated organizations, your Mount Sinai's, are actually doing this manually. And that's because they're paying for a successful outcome. So in other words, depression care. They're paying for a month's worth of depression care. And so in order to pay for that month's worth of depression care, certain things have to happen. I have to get a psychiatric consultation. I have to have a PHQ-9. So an organization has to track all of things in order to bill to get the case rate.
Is that like the former DRGs?
In a way, yeah. Mm-hmm.
Oh, it's almost like a bundle of payments.
So we're actually going to talk about bundled. Not quite.
Almost like,
Right?
It's not very
Yeah,
clear.
so the difference between the two that's helpful to remember, when we think about a bundled rate, like a lot of times people can relate to bundled rate like for pregnancy, right? So I get a bundled rate for all the prenatal services that I provide someone, right? And that goes from when they're pregnant to when they're not pregnant anymore, right? Easy, it's it. You're pregnant, you're not pregnant, you had a delivery, that's one bundled rate. Whereas case rate billing is generally by the month, and certain things have to happen, right? So I would get a bundled rate for prenatal care whether you kept 5 visits or whether you kept 1 visit, right? I would get a bundled rate. For case rate billing, certain things have to happen in order for me to bill. So that's sort of a way to really think about what the difference is, right? So one of the things you're going to hear about is really taking on risk. So one of the things that DSRIP requires, and that the system requires, and Patient-Centered Medical Home in New York requires, is that organizations be in at least one value-based payment contract with a payer, and that they assume some risk. So what does that mean? That means that I'm no longer going to get fee-for-service billing. That one of my payer contracts has to say, unless you get here, we're not going to pay you the full amount. And so it's a huge deal for organizations to start to take some risk, because a lot of things can go wrong when you start to take risk. You cannot have good outcomes. You have people that use a lot of services, right? And so this is something very new to providers, particularly behavioral health providers, right? So in order to think about this, there is a ton in New York of these innovative programs that Medicare, that CMS sponsored, right? To be able to reduce admissions, to be able to partnering for patients, comprehensive primary care, bundled payments for care around certain things, right? So these are actually models that are going on across New York to address some of the issues in the healthcare system. So essentially, I wanted you to really see how much is actually going on trying to address some of these issues, right? And then I wanted to talk a little bit about ACOs, because again, I want you to know everything that's going on so that we talk about screening and some of these things, you can sort of get the landscape, right? So who knows what an ACO is? I heard it.
Accountable care.
Accountable care organization, right? So what does that mean? What is an ACO?
I know what it stands for, I don't know what it means.
Okay, we'll let you off that. So exactly, it's accountable care organizations. They started with just Medicare patients. You had to have 5,000 Medicare patients to be an ACO, right? And in order to get patients attributed to your accountable care organization, you had to do an annual wellness visit with them so that they were attributed to you, right? And then you say, why would we do this? Well, because if you could manage that population of patients better and reduce the cost, you would get a piece of that savings. So that it allowed you to figure out ways to manage that patient better. You'd create a network, you try to manage the cost. So you'd say, okay, you're a substance abuse provider, we're gonna send you everybody in our network, but only if you can retain them in care and only if you can do it for X amount of money, okay? So I wasn't just referring to any old substance abuse provider anymore. I was having very different conversations, right? So now one of the flawed models, so if you think about it, right? If part of making money from an ACO is that I'm saving money on patients, right? So we're doing things better. Every time you're working down to patients who aren't as high cost or aren't as expensive. So instead of working your way to making more money, you actually work your way to making less money. Which is actually, the ACOs were kind of flawed. The design was flawed. And so that's why a lot of ACOs really struggled or are really struggling and trying to think about doing some of this. So that's actually, when you think about it, a bit of a problem.
Verna, could you differentiate the ACOs from the district networks? Because often they're overlapping.
They are really overlapping. So ACOs are predominantly for Medicare patients or Medicare populations. There are some Medicaid ACOs, but really most of them are Medicare, whereas your DSRIP and your PPSs are Medicaid. So I could be in a Medicare ACO, and my other organization was, and in 4 Medicaid DSRIP PPSs, right? And in an IPA, in a physician network association, right? So these multiple things, they overlap, right? And so that's why some of the staff were saying, wait a minute, I'm getting lists of my high-cost Medicare patients and we have to work those. I'm getting lists of people that are going into the emergency room from the districts. Which do I prioritize? Both. 2 separate things, right? So you can see some of the struggles being on the ground in the primary care centers, right? How difficult it is for them to be able to do that. And the state was really focusing on some of those high-cost patients. So I was part of a project actually where we had 61 patients that in 1 year were responsible for over 3,000 emergency room visits. And so those were the kind of patients that were getting identified and that you were really working on utilization. But once you work those really high group of utilizers, then, but that's actually what some of the DSRIP projects were.
Verna, can I do, just before you jump into collaborative
Yeah.
care, one other? So can you talk about I'm trying not to frame this in too slanted away, right? But the concentration of ACO dollars, right, even though it's supposed to be going less, and the concentration of district dollars at the tertiary care level, which is at the hospital level, which is not necessarily where collaborative care happens. And
Right. It's not where any care happens, right?
Yeah. So can you talk about those tensions?
Yeah. So, and I mean, I think the same thing applies to the ACOs, right?
Absolutely.
That you had to be big enough to have 5,000 Medicare patients in your system, who does that leave, right? That really leaves the hospitals. Yeah. So a lot of people say these initiatives were really bailout money for the hospitals, right? They're money going to the hospitals. And so that's actually been some sources of discussion, right? Especially when the people who are working the high utilizer list and providing the care are not getting the bulk of the financial gains from the districts or the ACOs. As an example, there was an organization who was in 3 district networks, and they received money from each of the district networks. And they took the number of patients that they had attributed to each network, and they divided it out by the money they got. And it ranged more than $20 per patient. So in other words, there was no method. It was completely up to the PPS how much money they gave you or didn't give you based on your participation. And so when that organization went back to the state and said, listen, there's a huge discrepancy. This PPS is keeping a ton of money. This is being a little more generous, and these people are being a little more generous, right? The state said, yeah, one of the things we probably should have done is put some methodology there so that there would have been some equity, and required that the PPSs give a certain percentage back to the providers in the network. And they didn't. So that was left completely up to the PPSs. So you can see how that might be problematic. So I want to jump a little bit. I want to just talk about collaborative care because when you talk about screening, you talk about collaborative care, and we're talking about models. So I really just want people to know about it, and anybody who knows me knows you're not going to hear me talk without hearing collaborative care. So when we talk about collaborative care, a lot of times people think, oh, we're collaborating around care, right? That's integrated care, which is a no, thank you. It is an evidence-based model that came out of a research project that was done in the early 2000s, 1,800 patients, over 400 primary care providers, which for the first time identified and treated a mental health diagnosis in primary care in a systemic way. It was called Project Impact. And so now, all these years later, it's interchangeable with what's called collaborative care. And why am I telling you this? That is because as of last year, it is now a Medicare benefit, and it is also a New York State Medicaid benefit. And so many organizations who are in DSRIP, it was also listed as a DSRIP project in 3AI. So it's important to know about when you hear about it because it really is an important thing. And here's some of the core components, but essentially it's a population-based treatment for patients with depression and anxiety. So for those of you who want more information, you can, but you really can't be in primary care these days or doing anything around integration without hearing about collaborative care or being a part of an implementation and being part of a patient-centered team like here. So I really want you to know about collaborative care. And one of the things that I also wanted to tie in is with now it being a Medicaid and a Medicare benefit, it is case rate billing. So that is why a lot of providers in New York State now are trying to figure out case rate billing because they're trying to bill for collaborative care. And Medicaid does it based on things that you need to do. Medicare does it on things you do and the time you spent with patients. And of course, they both use different codes. Fortunately, the third-party payers are honoring Medicare. But this is an example, and we'll talk about it more, of why people are struggling with some of this case rate billing. You can see all of the different things that are included and that have to happen in order to bill these case rates. So now I want to talk a little bit about value-based payment and screening, right? So thinking about value-based payment and episodes, let's just, because this is the way that behavioral health, particularly and primary care, are looking at value-based payment. So let's just talk about an episode. What is an episode? How do we define an episode? What is it? We're going to say, what's an episode?
When you're having a relapse or a breakdown of some sort.
Okay. So you could be having a relapse or a breakdown, and it's got to start if you have an episode, right? We have to figure out when we're going to start it and when we're going to end it. So if I'm going to pay you for an episode of something, right, we have to be in agreement about when it starts and when it ends. So if you can imagine how difficult that is, and let's just think about it for a second, right? So one of the things that the state was trying to do is figure out how to pay for an episode of bipolar. Okay? When would we start it? Would we start it when you walked in the door? Would we start it when you got a diagnosis, which might be in a hospital, and not when you walked in the door of primary care? Would it be when you walked in the door of the mental health center, right? Would it be when you had an assessment by a prescriber who confirmed a diagnosis? Would it be after a hospitalization? And then when would it end? Would it end when you've been taking medications for 6 months? Would it end when you haven't been in the emergency room for 6 months? How would it end? right? And would you need to break it down? So maybe there would be an acute episode phase and then a second episode phase, right? But you can see how complicated it would get really quickly. And then what if you were 3 months adherent and then you went back to the emergency room? Do we start the episode over again or do we extend that episode, right? So you can see right away how quickly this gets, right? And so what we did was I actually worked with the state and we tried to think about something a little bit easier, and we started to think about depression as an episode, right? Because they said we have to do something in an episode. So we started to think about depression as an episode, right? So let's talk about depression as an episode. How do you think we started an episode?
Probably like when there is an accident or a traumatic experience.
Think about depression.
Onset of diagnosis.
Okay, and how did we get to the diagnosis?
Patient comes in with symptoms.
Yeah.
Okay, and what tool did we use? We had to have a consistent tool. So we used the PHQ-9 score of 10 or above, right? So the minute you came in and you had a documented PHQ score of 10 and above, you started the episode, okay? And this is what the state collaborative care metrics they were based on, actually, right? So then, to end an episode, right, we said, well, you could have a PHQ below 10, but maybe that wouldn't end your episode, right? So we said for at least 3 months you had to have the episode. You had to be below 10, right?
If you had dysthymia or subsyndrome depression,
It doesn't, this
you
is,
can't get paid for that.
right, so this was, and you wouldn't from the state.
Yeah.
Right, because you have to show decreases. So according to the New York State 50% decrease or a subclinical, right? So that's how we ended it, right? So then we were able to say now we have a beginning and an end, and we were able to look at everybody who had a successful outcome in what the state was considering a successful outcome, which is a 50% decrease in your PHQ or a subclinical, right? And then we said, what did that take? How long did it take? And what did it take? How many times did they see primary care, mental health? Did they get prescriptions? How many changes in treatment? And how much did all that cost? So the state reimburses about $150 per month per patient in collaborative care. So they wound up not doing it by episode, but doing a monthly case rate. But defining an episode of depression is something that people are still looking at in terms of really thinking out how to pay for episodes.
So, Bernie, if there's a comorbidity, so a different case rate without complexity.
No. Because you're only getting the case rate to treat the depression. So you can enroll someone in collaborative care who has multiple comorbidities, medical and mental health, right? Who may be more complex than the next patient. The outcome is still the same, the case rate is still the same, doesn't matter. Yeah. So that tells you a little bit about just even the complexity of providing some of this care, but how the state is looking at some of these, right? So, and then what they actually did was went through and really looked at everybody that touched that patient during that episode so that they could try to figure out how much does it actually cost for somebody to be in collaborative care to the point where they have the 50% decrease in the PHQ-9 and the subclinical, right? And so that actually is something that was really looked at for the first time, and that's how the state and Medicare and some of those came up with those monthly case rates. But when we tell organizations, when you're figuring out and you're looking at doing some of these models, will help you if you can define that episode, look at the average length of time and look what it takes. It's going to help you put a cost to it, and you're going to be able to figure out your staffing. You're going to be able to figure out some of those pieces. And so that's really what you want to try to do. And then you can figure out how you're going to care for patients in your organization with depression, because we're talking about depression. And so then you want to start to think about, how are we going to measure, right? How are we going to look at these things, right? Where are we going to, what tools are we going to use? How are we going to collect the data? So in order to do this, we had to have providers put how much time they spent with patients. So we looked at the CPT codes, we looked at the time spent, and then there's a lot of things that don't get coded. If I have a patient and I made 50 outreach calls, that's not something that gets coded or billed for. So we had to figure out a way to track that, because that's important information and it takes somebody a lot of time to do that, right? So that all gets figured into your cost, and it's important information for the world to know, hey, if you want somebody to be successful here, one of the things that, on the average, you have 50 outreach calls, as an example, right? So these are really hard things to track, right? And how do you put that information into your system? So at the end, what we really encourage organizations to do is develop pathways, and that will help them think about episodes. It will help them prepare for value-based payment, and it will help them identify ways to care for those patients in their system. What tools, how they're identified, who. Very different than a workflow. A workflow is like who does what and when. This is how we care for patients with depression in our organization, with ADD, whatever it happens to be. And so now, as we're doing this work in organizations, we're really encouraging them to develop pathways. So now, thinking about screenings, right? Because I did promise Sean I'd talk about screenings. So I like to keep my promises, right? Mostly.
Always.
So let's talk about screenings in primary care. So first of all, why are we screening? And then let's talk about what are we screening for. So why are we screening and what are we screening for? Anybody know?
Because depression is very common.
Depression, okay? Right.
Serious comorbidity.
So we're screening for depression, we're doing the PHQ-2 mostly, right? Okay? What else are we screening for?
Substance abuse.
We're all experting, right? So we're screening, right, for substance abuse, right? Absolutely. What else are we screening for? If we're a primary care provider particularly, what are we screening for?
Sorry.
Anxiety, GAD-7, right? What else are we screening for?
ADHD in children.
ADHD in children, we're probably using the pediatric symptom checklist so we can catch a couple of different things, but yes.
Possibly post-traumatic stress disorder
Okay, or trauma.
or trauma.
Right, so there's a big push now. I'm actually with Kaiser and the National Council on the National Trauma and Primary Care, whatever they're calling it these days, initiative, right, to encourage primary care providers to screen for trauma. What else?
Domestic violence.
Okay, intimate partner violence, family violence, right, screening, okay. What else?
Smoking.
Okay, so maybe some thought disorders or bipolar. A lot of organizations won't screen for depression without asking a bipolar, whether or not somebody's bipolar, not necessarily doing an MDQ, but maybe asking one or two questions, right? Okay. What else are we screening for? There's one more big one that. Suicide, absolutely. Okay. So now a lot of organizations are not just doing the PHQ-2, they're doing the PHQ-3, and they're asking the suicide question directly. What else are we screening for?
Alzheimer's.
It depends on the population, maybe the thought disorder, right? So yes, absolutely. Social determinants. Primary care is being asked to screen for social determinants, right? For food insecurity, for homes, right?
Okay.
Okay, so I don't know if anybody was counting.
At least a dozen.
At least a dozen, right? So you're a primary care provider, and you're expected at this point in time to be screening for those things.
And one test, like, to do that.
Right. And so, why are we doing that?
Save money in the future.
To save money, right? Right, okay, right. So we can try to identify people, right? So the most common workflow in primary care is that I come into a very lovely mostly very well-meaning, generally poorly trained medical assistant who is responsible for seeing me prior to the primary care visit, who's going to take my blood pressure, tell me that I'm as fat as I was last year with my weight, right? Is going to check my pulse, right? Do all those things, right? And ask me all those screening questions. So you can see where there might be some ways that goes wrong, right?
Yeah.
So those are some of the struggles, but that gives you an idea. So I had somebody very lovely call me the other day from NYU, and they said, we're doing this project on ADD, and we really want to bring community health workers, I don't even remember, right, into primary care, and we're going to do something with ADD. And they're going along, and then they said the word screening, and I said, stop right there. I said, you want to do what? And they said, well, we have this screening tool. And I said, stop right there. I said, I'm not interested. I don't want to hear it. I am not going to take on a project or participation in a project where I have to go into any primary care office and talk to them about using another screening tool. Not happening. The likelihood of success of that is going to be an uphill battle. So think about how you can use something existing like the pediatric symptom checklist and make that work.
Bernard, you identified 7, maybe 10 different behavioral health related screenings, right?
Mm-hmm.
For primary care. And those are on the behavioral health side, right? Those are not on the medical side.
Right.
So that all of that is layered onto what has traditionally been conceived of as primary care.
Exactly.
Right?
Yep.
So it's an additive issue, right?
Yeah.
On the behavioral health side,
Mm-hmm.
we often argue,
We're getting there. Yep.
we often argue that, well, but you have the patient there.
Right.
And we know all the literature around, if every primary care physician did every screening that they're supposed to do, as recommended by the United States Preventative Services Task Force,
Yep.
they would have 17-hour days just
Doing
doing screening.
screening,
For the
right.
patient, right? So, and we know that.
Right.
On the behavioral health side, they keep saying, but just do this screening.
Right.
So we keep trying to do square peg, round hole.
Right.
So you know where I'm going.
Yeah.
So
And
what's the alternative? Like,
so I think there's a couple of pieces, right? So one is to really think about this, but going back to behavioral health providers, right? Because I'm all about shared accountability. And so one of the things is that behavioral health providers often see patients a couple of times a month, where maybe they don't come into primary care that often, right? Maybe they come once every 3 months or whatever, right? And so behavioral health providers, so in my system previously, my behavioral health providers were just as accountable for flu shots and PAPs as the primary care providers were.
so see more about what is that?
So that means that I say, so I noticed while you're in today that you haven't had your flu shot. So after our session, can I send a note to the nurse and you can get it on your way out, right? That as you're thinking about changes to the system, as you're thinking about creating integrated care teams, then one way to get primary care buy-in to do some of these behavioral health screenings is to say, well, we'll help you with your quality measures because I see that patient 5 times a month and they've missed 4 mammograms that you've sent them for. And so maybe I have a conversation with them that says, you know what? You've missed a couple of your mammogram appointments. You know, I know that sometimes patients who miss their mammogram appointments have a history similar to the one that we've been talking about. And so maybe in our next session, we can talk a little bit about how we might work with you to have your mammogram done, because that's a really important piece for your health, right? So that we're having very different conversations with patients to really reinforce, and behavioral health providers now, as part of value-based contracting, and in fact, they're responsible for quality measures, for medication adherence, for diabetes, labs, right? For A1Cs and all of those pieces, right? And so thinking about that shared accountability, and they're screening people for diabetes, and they have to do some of those things, right?
But do they have any medical training?
So
It's MI. It's essentially motivational anything,
Yeah,
right?
it is exactly the same
But
thing.
they're not actually
Doing it.
reviewing the labs.
No, they're just
Well,
trying to get
actually, the
people to go.
prescribers are reviewing the labs, and they're responsible to order labs and to review them and to make sure that people have them. Absolutely. Yeah, that's a quality measure.
But that's confusing
question.
to me,
Yeah, you're
because
asking the-
who is the provider that's doing that?
Yeah.
I mean, is the social worker reviewing the hemoglobin A1C?
No, although, I mean, I could look and say, you know, it looks to me like you should probably talk to the doctor because I know that I've been in medical care, right? But the prescriber, so if I'm in a mental health center and I have diabetes, right? And you're prescribing medications for me, or if I'm at risk for diabetes because of medications or because of other risk factors, it's your responsibility to make sure that I get labs done and that you review them and have that discussion. You're held responsible for that now. And as a non-prescriber, I'm also responsible for preventive health measures to say, did you get your flu shot? Have you had your PAP? Did you go for your sugar check, right? All of those things incorporated into the care that I provide.
So what if the patient doesn't? I mean, what if they just don't go? So then what
Right.
happens?
So that does happen, and that's something maybe you continue to address or talk about, right? Yeah, I mean, it happens, right? I don't go to primary care, I don't go to behavioral health, I don't get my mammogram, but those are right, but those are things that you continue to take up in treatment, right? And maybe it becomes a goal, maybe you're talking about how it relates to what they're in care for, right? Certainly. So those are some things to be able to think about. But these screenings, when you talk about screenings, these are a huge issue for a lot of practices, both primary care and behavioral health. And the thing about screenings,
I'm just gonna go back on the other point, but I guess I'm curious about the risks of having behavioral health specialists make recommendations for healthcare, because then doesn't it change a little the dynamic between the patient and the specialist?
it actually says that you're all connected, right? That you're part of, that we care about your physical health and your mental health, and that they're connected, right? If you're feeling sad, I know that it's difficult to get care for your diabetes, right? But there are times when, your physical health is going to affect your mental health, and making that connection for people, and then it's really a part of, so many times I see behavioral health treatment plans, and I look at a problem list, I see obesity, I see insomnia, I see smoking, and it's never addressed in the behavioral health treatment or the treatment plan.
Wow. And that they're seeing the same patients.
They're
so
seeing the same patient,
How can
and
they address the comorbidity if basically one doesn't do
Right.
what
And so part of cross-training our providers, right, is this idea of shared accountability. So if I'm in a primary care office, right, we're teaching primary care providers how to do safety plans, because a lot of people who die by suicide, the last person that they saw was their primary care provider. It wasn't a mental health provider, right? So mental health patients who have serious mental illness die sooner because they have these chronic illnesses. So it's our responsibility as behavioral health providers to really make sure that we're bringing those things into care, so that the people we care for aren't dying 25 years sooner from heart disease and diabetes and all of those other pieces, and really incorporating that into the care that we're providing to our patients and having some of those discussions. And generally what you find is that as you start making those connections, people, what their response is that you really care about their entire health. And that a lot of times the way that we teach providers to talk to patients about screening, so we've been talking about the PHQ, right? So then I say to patients, a lot of times, this is like your emotional sugar, right? If you're not feeling well or doing well, it goes up. And if you're feeling better, it goes down. When you come into the office, we check your sugar. If we didn't, we wouldn't be doing our job. So now we're going to check your emotional sugar every time you come in. And your emotional sugar, your PHQ score is a 21. We know that we want to get your A1C here. Well, we want to get your PHQ below 5. And really making that comparison, your emotional blood pressure, your emotional temperature, right? So that you're making the connections for people as you're doing this work. Yeah.
So for me, there's just a piece missing on the logistics. You went over the budget carefully.
Okay,
But in the collaborative care model, and I've read the impact study,
sure.
the primary care provider has a certain responsibility for that brief intervention in that first session. And, you know, when I used to do behavioral care in primary care, the dilemma was we could never bill because we were not behavioral health providers. So
Yeah.
that's the piece
That
that I was
has really
interested in
changed.
hearing. Yeah.
That has dramatically changed.
So how do they bill? What do they bill? And
So there's a lot of ways to bill, actually. So if I'm behavioral health in primary care, again, depending on my licensure and the kind of setting, it varies, right?
well, if you're just an ordinary
Position.
physician,
Primary
nurse
care,
practitioner,
yeah, sure.
Providing
without the-
primary care, so there are screening codes, so you can bill for the screening codes in many instances, right? So you can bill, we've been prodding the people in our maternal depression collaborative, I have to be mindful of my friends at Greater New York, prodding our maternal depression folks to use the maternal depression screening codes because they get paid $15 a pop. And then the payers can track it, right? So there's definitely reimbursement for the screening codes, but for all different kinds of screenings.
So is there reimbursement for that brief motivational intervention?
Sure, so if I'm a primary care provider, if I'm an NP or a PCP, I'm gonna do a couple of things depending on where I am, right? I'm gonna use an E&M code for the time and complexity for that visit, which may be increased based on the fact that I'm spending some extra time. Or in some settings, and if I'm spending 15 minutes and doing an expert visit, then I might use the expert code and get paid the additional reimbursement from Medicaid. So it really depends on, you know, where they are and what they're doing, but certainly the reimbursement is there. And what we do is work with every organization. This is the kind of organization you are. These are the kind of providers you have. These are the payers you have. These are the services you provide. These are the codes you can use. And we sort of work them down a list to optimize their screening revenue, their provider revenue, you know, all of those things. But it gets incredibly complicated, you know, particularly around some of the screenings because there's all different codes. So Medicare uses a set of codes, Medicaid uses another set of codes. There's codes for maternal depression screening. There's codes for substance abuse screening. So, you know, you need to build all of those into the system. And that's part of the complexity. So when you talk about getting an organization to implement a screening tool, right, then think about all of the things. So if we talk about them implementing, we're going to go to a primary care organization and they've said, okay, we're going to start screening for depression, right? So the first thing we ask is, who are we screening? So if they're a primary care organization, who should they screen for depression?
Everyone?
Everybody? So is that people with cognitive deficits? Is that people with bipolar on their problem list? Who should they screen? Do they screen 5-year-olds?
What about mothers? I would say like if we're
You'd want to screen, you definitely want to screen mothers, right? So the first thing is to really work with them on who they're screening. We're going to screen everybody ages 12 and up, except the people who have all of these diagnoses on their problem list, right?
Okay.
So but you really have to help them define that population, right? And then you have to figure out how they're going to do that. How am I going to know if I'm somebody who's screening that somebody's bipolar or that somebody, you know, so you have to figure out that. When are we screening, right? So how often are we going to screen? One of the things we know is that if we screen people every single time, there's lower yield rates. So every time you come in, if I screen you for depression, we're going to identify less people because it gets perfunctory, right? So we tell organizations screen once a year unless you test positive for pregnancy, you get diagnosed with a chronic illness or something, like maybe there's some reasons you would want to screen people again, right? But we don't want to screen people every time. Why does health and hospitals screen people every time? Because they can't figure out how to do it differently in their EMR. Okay? So sometimes organizations can't figure out how to do it differently, right? So, and then who are we not screening, right? So then to really take those people out, right? And then how do we document the screening? So I was in an organization today, they have patients fill it out on paper, they scan it in, then they have no way to know whether or not somebody was screened. And they have no way to track who was screened. So I was on the phone with the maternal depression people, right, with health and hospitals. What did they say? I'm not picking on health and hospitals, it just so happens they're fresh in my head, right? And they said, we have this facility, they have no idea unless they go back and look at every single chart to see if a PHQ was scanned in the chart. Okay, so the likelihood of that being sustainable to track screening is pretty low, right? So then we have to think about how are we going to track screening, right? Like what is that going to look like? Are we going to use codes? Do we have to build them in, right? And then in order to get paid for screening, we have to use the codes, we have to document it, right? So then we have to build it into the EMR. And then is it up to me, the provider, to enter it? Or is it something that's going to populate automatically, which is a much better thing, right? And then, how are we going to train people to screen? Because that is certainly where we see, if we go to an organization and we look at the screening rates, and then we look at it by provider or by the person doing the screening, huge differences. You might screen 100 people and 25% screen positive, right? You might screen 100 people and 2 people screen positive. That's a training issue because it's the same population, right? And so then we need to go back. So this is like often working with the organization. And then we had an organization in the Bronx. They were great. And then they had a big problem. They fired all their medical assistants, right? So then all of their medical assistants had to be retrained and their depression screening tanked for months. Yeah, and then.
So I have 2 questions. One, Kim, I wanted to circle. I don't know if you got your question answered, so I wanted to circle back. Is that what part of the relationship were you worried about? So you
I was
asked, did
worried
it
about
change?
the behavioral aspect, because I think that a mental health professional, when they're seeing a patient, there's a certain dynamic and a certain relationship, and adding this dynamic of kind of encouraging that person to do something for their health, not to say that it's not a good thing, but it can change that dynamic into a different sort of power dynamic.
It's power, so I was hearing confidentiality concerns. But
No,
then
not
there was you were going
confidentiality,
to
power.
No, comfort, yeah.
So what would you do with
I see what you're
substance
saying.
abuse? So if I was seeing you and I was using alcohol and you were talking to me about my alcohol use and potentially referring me for treatment, how is that different?
Well, I'm not a mental health provider.
We don't play one on TV.
I mean, and so I was thinking, I think that I can see the parallel in what you're saying, but I was thinking more about somebody that comes in, like as you had said, like for something like being bipolar.
Right.
And that if you, of course, like you want that person to take their medication and there's going to be the conversation because maybe they take their medicine, they feel better, they stop taking their medicine,
Right.
back and forth.
Right.
But that's also the person that's prescribing that medicine, the behavioral health
Maybe,
person versus
maybe not.
maybe not.
Right.
But I was thinking that if you said to somebody, the mammogram example, what happens if that patient doesn't want to come back to you for the behavioral health because they don't want to go for their mammogram and that's not what they want to discuss when they come in.
Right.
And so then they get deterred.
Right.
And so I was wondering about the risk and then wondering about whether or not you can track that to see as you have more of these conversations that
Right.
have a clinical dynamic to them, are you losing patients as a result?
So the answer to that is actually no. People become more engaged because, and it's about making the connection for people. And you're going to talk about a lot of things in treatment. So maybe it's about leaving or changing an abusive relationship. Maybe it's about smoking, right? And it's about making the connections for people so that they can see how their mental health and their health and some of the other components of their well-being are all connected. And I think that's really where the conversations are, and saying that I care about you as a whole. And these are things that you may want to set as goals as you move towards wellness, right? And wellness is not just mental health wellness. Wellness is wellness, right?
Mm.
And so, and what does wellness look like for you? that you would be physically healthy, that you would be spiritually healthy, that you would be emotionally healthy, right? And bringing all of those pieces together. So when you think about wellness self-management, right, a hugely successful evidence-based, so that's what it does. It talks about all of those different components, right? So, but yeah, I mean, I understand what you're, but I think it's, and I think behavioral health providers are also learning how to have these conversations and work with patients to sort of make the, the connections. And so one of the things to think about is then, also what should happen after screening, right? So we've had a lot of providers say, I'm not going to screen for trauma. I'm not going to screen for depression. This is famous again in our maternal depression collaborative. I'm not going to screen for depression because I have no place to send patients, right? And so one of the things that we talk to them about, well, first of all, we know that having a conversation with a provider and getting information and education on depression or trauma or whatever it happens to be is actually helpful. Giving patients educational material is helpful, right? Mm-hmm. So there are things you can do, which is better than doing nothing and not screening. So I tell people, so nothing is not an option, so let's talk about screening and then what you could do if you don't really feel like you have, some different options, right? And so, but you can see from all of these pieces, right, how complicated it is if you're talking about 10 different screenings and all of the things you have to consider for each one of them. How are we tracking it? How are we building it in? How are we following up? How are we putting it in the EMR? How are we coding for it? What are we hoping to get out of it? Who aren't we screening? How often are we screening? And putting an algorithm in place for every one of these different screenings. And the kind of complexity that brings, and then training people to do it. And so, as we're doing this, so when you think about collaborative care, so we were all excited when we got $15 million put in the New York State budget for collaborative care billing, right? Yay, we were deliriously happy, right? They actually got money taken away because of the underbilling. Because putting these systems in place is so complex for providers, figuring out the case rate billing, figuring out the screening algorithms, training staff is so complex, and figuring out the workflows that even the best organizations with the most infrastructure, right, who really have a team, who are genuinely working on this, it takes them so much time to get to the point. There's only a handful of organizations in New York State that actually have full caseloads for collaborative care. And so I think that's something to think about, putting this in perspective, right, about how complicated some of this is. And if you have an organization where you can't make changes to your electronic health record because you're under a certain contract or because you work for a huge organization and the likelihood of you getting a change that you want is near zero, right? So you can see how sometimes these things just feel hopeless to some of these providers that are in the field, trying to make some of these changes and do some of this work. And so hopefully, one of the things that you come away with today is an understanding of all the things that are going on in the system and how complex the system is, and then all of the things that the system is trying to do around these screenings and how complex all of them are, and all of the things that you have to take into consideration about what you're going to do, how you're going to hire, how you're going to bill, what kind of a center you are, how you're going to implement all these screenings to really go from beginning to end. So, thank you very much.